Direct primary care is an innovative alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
So we are jumping in. This is my treatment for FOMO because I wasn't able to see Amber as much as I would have liked at the DPC Summit. And today we're going to be talking about something that is very pertinent to people if you are looking to hire staff, whether it be virtual or whether it be in person. And Amber, as those listeners who've listened to the podcast know, has multiple locations and she has multiple staff over the years at her DPC. And so whereas the healthy human is what she focuses on, that is her brand, she has lots of humans that she is managing at her practice. And I have had multiple virtual assistants. I have not had anyone in person. So this is where we're going to go today. So Amber, let me ask you, who is on staff right now at Healthy Human?
Yeah, as of right now in 2024, we recently had our PA leave that had been here for 3 years. He went back to the hospital setting that we just left. So both him and I had been employed by the local hospital, and he is now back working for them at their clinic. He was just looking to be back into the employer world, somewhere where his clinic is just filled every day and he had more structure. That is probably one of the biggest things about DPC that I think anybody has to get used to, whether you're an employee or whether you're the owner. There isn't a lot of structure. You can try really hard, but I never know who's going to call every day. Just the same thing in clinic. We never knew when we worked for the hospital who was going to call every day. But the difference was, with the hospital, my clinic time might be filled in advance for weeks. So I kind of knew what I was doing and had structure, and so did my staff. That's just different when you're self-employed because you might have what's already on the calendar, but no matter what calls in for the day, you have to take care of it, right? And it's up to you to do that. He needed that structure, and so he had left in May. And now we have a physician that is locums that does PRN work for us about 4 to 5 days per month. And she's filling in for us while we wait for a new employee from a PA realm. And we actually did just hire one last week. She's going to be starting in October. So that'll be nice to have somebody back on full time with us. And then from a ancillary staff or staffing perspective, nursing, I have 2 RNs and then I have 2 LPNs and then also an office manager or admin assistant that helps us run the locations. So in the past, we have had 2 other people come and go. One of them was the very first nurse that started with me here. I still miss her to this day, Emily. She was great. She is now working for the local hospital as well. And then our office manager that left 2 summers ago, her husband and her own a business, and he needed help at that business. So I had lost my first time office manager that I had trained and now just go back to pretty much doing most of it myself. And that is where we've been in pretty much 6 years.
Thank you so much for sharing who's on staff right now and what is happening actively with staffing at your practice. But I just go back to Matt and this idea of structured schedule, because for me, I don't allow patients to self-schedule. I revel in the ability to have the flexibility that I never could have in fee-for-service. And I see you nodding your head, so I'm assuming that that's something that you love too, because I think about back in April when the tornado hit your guys' area, and I was like, are you okay? Like, where are the boys? And you were like, they literally just got dropped off at the bus stop. And it's for you to be able to pivot and be like, I need to be where my boys are. I need to be where I need to be because I am a doctor as one of my hats, but I'm also other things. And the flexibility to do those things I love about DPC. So it's interesting to hear that the being booked out in advance provides a different way to deliver healthcare. I was never for that just because, yes, you had people on your schedule, but you only had so much time per patient. So it's so interesting to hear that. And absolutely, there's nothing wrong with it. Like people go back, they have to sometimes if like finances happen and they're not able to continue on in whatever structure they're doing in fee for service provides them a more stable income, without certain hats of being an entrepreneur. Fine, I get it. But those are just my thoughts hearing about Matt going back to fee for
Yeah.
service.
Yeah, I get this because I can see it happening, but it's not my life. So I hire on for a full-time mid-level, and they are not going to be as full as me unless they have a full practice. And he did not have a full practice and I did. So I can see where it would be hard to have all that dead space of not having a full schedule. And what do you do with that, right? You really need to stay around the clinic. So then that way you can be there if somebody walks in or if it's needed. But at the same time, that's a lot of downtime and you can get anxious and your thoughts can go all over the place. Well, for me and you and whoever are the owners, we're just so busy all the time that there really isn't a lot of dead time. And that's one thing, even with hiring on for our new PA, is that just explaining that you're not going to have something 100% of the time unless you have a full practice. And I don't know how long that panel might be. That panel, it might take years, or you might just be sharing with me and seeing patients with me that whole time. It's hard to know, but trying to set expectations. And I think from a staffing perspective, that's what I'm always trying to do is set expectations of, I hear you, I see you, I know what you're going through, but then there's reality. And you have to decide if you're okay with that reality, right? Because that's a thing that I think I learned pretty quickly is that you can really burn out trying to make everything perfect for everybody, right? I can't do that for my staff either. They have to be okay with what this job entails and what it looks like, or they might just need to move on because I'm so busy 100% of the time that I can't try and make everybody's world perfect and make it work for them. This DPC situation is really what we all went to so we could get a breather. We could do medicine on our own time in our own way. And so it's really quick and easy to get wrapped up into trying making DPC work for everyone that you've employed. And you have to remember that, yes, you want your employees happy, but at the end of the day, either they're happy with the location that you've put together and you've made and the atmosphere you've created, or they're not, because it can really tear you down trying to make sure everybody's happy with every little thing, because it is a constantly evolving world. And I do like to have a lot of control over my schedule and leave it open as well and not let people self-schedule because of things like that. We've had tornadoes, yes, but we've had flooding and we've had storms, and Blair's just been hit like crazy. Nebraska's been hit like crazy this past 6 to 8 months. And we never know when we're going to have time to see people that are acute or, yeah, we have baseball that we just survived through, and baseball is crazy. I mean, I never know if I'm going to have to leave to go coach or leave to go to state baseball. And so leaving those holes in the schedule so I can see people that call up and need acutes and I can kind of triage and not just have a ton of chronic things filling up my schedule. And that's what my previous job looked like, is that I really had no time for acutes because my whole schedule was filled with chronics for days and days to come.
Yeah. And it's one thing to think about, especially as you're growing your practice. If you don't have staff and you're thinking about it, or if you have staff and you're like, Amber, your words are speaking to them. Everybody is where they are in their journey. That's just where we are. And you just sort of mentioned these expectations that you have for a person. I think that it has really helped in my journey of learning how to be a better employer and manager of other people, to figure out tasks, expectations, and then objectives to evaluate whether a person is meeting those. So I wonder, in terms of your staff, your LPN and RN roles, how do you assign tasks to those individuals? Is it based on role, or is it based on like, here's the general set of tasks that we start out with in your role because of your degree, and then things are added to their roles as you see them work?
Yeah. Well, I always tell my staff over and over again, I don't have to tell them as much anymore because now we've worked together for years, but I had to tell them a lot at the beginning that everybody I hire for a reason. And the reason isn't because they all look the same. The reason is because they all look different. And we're in a very competitive career. I mean, we might say that we're not competitive, but at the end of the day, we all want to be really good at our job. We all want to do what's best for the patient. We just want to be on it, right? And we're used to being quick at what we do and thriving. And so I think a lot of times in an atmosphere, it's really easy to start being like, well, no, so-and-so does this better than me, or I want to do that task, or why don't I get to do this? And I just really made it clear when I hired all of these ladies that they're all being hired for different values, skills, traits, even the way some of them cheerlead others on. It's a completely different reason why they're here. And that's what makes the team. That's what makes us cohesive and work well together. And so when we did that, I knew that I was hiring each of them because they all had their own skills and traits and they would really make this ship float. But it did take years as we worked through just working together of really whittling down what that role looks like for each person. Because even some of the people that at the beginning I thought should be doing the same tasks, we realized that one person may be way quicker than the other one. And now we've made like a nursing role where that nurse does all the nurse appointments and the other nurses just maybe are delegated to help here and there if they need assistance. And instead they're on the phones or they're doing paperwork or they're rooming patients. We used to, when everybody first came, when we didn't know who was the strongest in each of their own like little knacks or fields, we would have everybody doing everything and it was chaos. I mean, the reason I say chaos, and I had to explain this to my staff, when people try and trump their owner, right, the physician, the one that's supposed to be overseeing everything, you can tell where everybody should be, when they should be there, how it should all work. So if somebody is trying to trump my decision making, then we might have an issue. And it's not because I want to be the one that's only the decision maker. It's because I have to do a good job also of explaining to them why I'm making that decision. So for example, really easy thing, but it can implode our world. You know, when we first had these two nurses and two LPNs that started together, everybody wanted to see their own nursing appointment. So for example, one of them wanted to be drawing labs, one of them wanted to be doing an injection, one of them wanted to be doing X, Y, and Z. And they were scheduling them all within like 10 and 15 minutes of each other. And I had to stop them and explain, like, we can't do that because we don't even have enough spots in the parking lot for people to come, 4 different appointments at the same time. Because then on top of that, there's people parking that need to come in and see me, and then somebody needs to room them. It seems so trivial, but they're like, oh yeah, we don't have that many parking spots. And there's people complaining that they can't park and that they're on the street and that so-and-so almost got hit. And it's things like that on managing a clinic that it even comes down to how many parking stalls do you have? And so it was at that point that we said, okay, only 2 nurses can be seeing appointments at the same time as the doctor can. And really, in all reality, we'd love it if only one nurse was. So you have a nurse appointment and a doctor appointment, and that's it. That takes up 2 parking spots. And then you have 2 more in case somebody wants to stop and pick up meds, or if they randomly check in or come early to their appointment. But I mean, it's things like that in a clinic, and even trying to decide what roles your staff has, that it can implode your clinic or it can make it run really smoothly. Those are just, it's one of the easiest examples I can give of why it's important to explain to your staff why we have roles, and then also who's going to have the role, and why I'm not just shouting out commands just for the heck of it. There really is a rhyme and reason behind why I'm trying to make these decisions. They always say there's always methods to my madness, and I'm always overthinking everything so it works right. Sometimes wrong, but it's those reasons why you have roles within a clinic, because that's what makes it run smoothly and more efficiently.
So let me ask there, when you are whittling down what is a person going to do, and that is constantly moving, how do you set time aside to whittle down? Do you have team meetings? Do you have weekly meetings? How do you pivot with what is going on at your practice, or what you realize like, oh, this can't happen? How do you adjust going forward?
Yeah, we do have team meetings. We used to do them monthly, and then it kind of came down to where somebody would talk in the hallway, or you'd run into somebody and you'd feel like you need to inform them before that month comes up. And then it would almost seem like we're sitting down to have a meeting and everybody ended up finding out what we already knew anyways. But we have found that when we cancel them, then we have some people that are more informed and some people that aren't as informed because some need more time and others don't. So we do tend to have that meeting, and we range anywhere from every 4 to 8 weeks. So right now in the summer, we're about every 6 to 8 weeks for a meeting. We do go back over things again. We just make sure everybody understands, and then we try and move forward. But it's at those meetings that I feel like I do learn about what's going on with some of the nurses, and then Brooke, our admin assistant, what's going on in their world that maybe I thought I knew how it was working. And then I have them walk me through it a little bit better. And I'm like, okay, now I understand. But for the most part, you can see as you walk through the clinic and how things are being laid out, how people work together, what's getting done and who's doing it. I would say that the easiest thing for us was to let the nurses kind of mesh together and delegate amongst themselves of what they feel is appropriate. We chose to give one or two people the roles, and then as far as even like the mentions and the tasks, and then let them delegate off from there. So then they could decide as a team what person needs to be doing what on each given day since they work on different days. But otherwise, I'd say most of it came from just listening during staff meetings or even just watching throughout the clinic and seeing who's doing things quicker, or maybe who's doing things more often because it's ended up just falling in their lap because they do it better.
And as you have experienced churn within staff at your practice, I want to ask about, you have churn, your tasks have to be redistributed, the tasks that you take on, and you're like, okay, this definitely does not require a doctor's level, or it does not bring me joy to do X, Y, or Z. How do you handle, okay, I don't have this staff person anymore. I'm doing it, but now I need to figure out a way to not be doing this going forward. How do you go through that process?
Well, that's really interesting to ask that right now because I had said at the beginning of the conversation, I'm probably not the best person to talk to right now because one of my employees that has been here for quite a long time, she is no longer going to be with us as of this week. And so for the last 6 weeks, we've actually been orienting her role to the other staff. Just kind of unfortunate circumstances, but some policies that aren't being followed. And so she's going to be moving on. But I did ask her, instead of leaving right away, could she stay on and train for 6 weeks? So she's been working on orienting the other staffers. And essentially what we did was for the first couple weeks, I just had people kind of ask her questions that they came about on, how do you handle this? And when you're gone, how should I do this? How should I take care of this? But it really didn't work great because I feel like the day gets so busy that people don't really ask. And then it's kind of like, well, I don't feel like we're really using her like we should. So then on the last 3 weeks of her being here, what we decided was we'd essentially just kind of act like she wasn't here. So we were going to use her to room patients. And then the other staff was going to get all of the tasks and mentions, and I would essentially send this person typically. And then if they did need help on anything, they would have her to ask while she's still there. And so that has worked really well. I have checked in with her a few times. There's people that have been asking her about X, Y, and Z, maybe like prior auths or something admin wise or scheduling appointments or even meetings. That's been a good orientation and a way also for us to delegate tasks without me necessarily even delegating it. I just sent out the tasks and mentions that need done that would have typically went to this staffer. And since she's not there anymore, the other three had to decide who was going to take over that job. Or was it better if they just all three worked on it together and they just kind of split the pot? The only thing I couldn't really do that on was, well, I could, but I'm just a little hesitant to do it. She also submits our pharmacy numbers for the day to the PDMP database. And since that is under my license at the end of the day, I do get worried that could get messed up because no one's been doing it but her. And so I feel like I need to take that on. I do feel like that's a very big waste of my time to be doing this. It doesn't take very long. But dang, Microsoft, they work so much slower than Macs and Apples, and I have to do it on Microsoft. So I'm actually going to Costco today to buy a new computer because our Microsoft one we have is so slow in the pharmacy that I'm so impatient. I will not sit the 10, 15 minutes to wait for this Excel thing to populate and do what I need to do. But that's going to be really one of my biggest pains in the butt when she's gone, is working on that because I know that it has to be right. And so I'm almost scared to delegate that. And there's going to be things like that you're going to find that you don't want to delegate to someone and you just have to do it. But at the end of the day, it would be great to have an office manager to delegate all these things to. For us, I spent 7 months trying to orient an office manager. She was awesome. She was just about ready to fly when her husband needed her to come back to the job. And for me, I'm like, that's 7 months I'll never get back. And it was 7 months that my child was under one and I could have been with him. And I honestly was not with him at all because I was so busy trying to train people. And I can't afford to have another 7 months of my life go by without my kids to have someone leave again. And I think that's the hardest part about private practice is that at the end of the day, it is yours to own. If somebody goes, you have to know how to do it. And I think my biggest fear is getting so far away from it that I won't remember how to. And then am I going to let people down as a boss because now I can't even do some of the most trivial things? So I do hold myself back on some of the patients I could see because I'm doing that. There's times I don't really think I'd need a mid-level if I would just see all my patients. The problem is then who's going to do the admin side? And I'm just not somebody that's lucky enough that has a spouse that gets to jump in and do that. So I have really no one else that I can trust that will be there every day and not leave.
Absolutely. And do you harness Loom videos or recordings of what you've done, especially onboarding that office manager, to have a library of stuff for people to reference?
That would be a really good idea to do that. I have a list of everything that she typically does in a work week or a month. So then that way we could delegate. I have the same thing like what I do from an admin side, but I don't necessarily have any videos. And I guess in my mind, it's because it is one of those things where it wouldn't be very hard to teach or train. So I guess I just don't do videos of it, but I do have lists of what each person's role would be.
And my next question off of that is your team that I've always known it to be in person. Have you ever explored a virtual option to bring into your team?
So we were sitting at DPC Summit this year, and I had known that there was a chance that this staffer was not going to be here with us. And I started listening to everybody talk about Hello Rach, and I started thinking maybe this is something we need to look into. I just think anybody, and maybe this is being too cocky and having an ego, but I feel like in a rural setting, there's just no way to utilize that. Our town is so used to it being people they know. And I always tell myself that I don't think it would work. Maybe it would, and I just need to try it. But every single one of my staff are people that all these patients know and they see out in town. And so for me, I just always feel like that Hello Rach wouldn't work, but it probably would from like an admin paperwork perspective. I just don't know that we have enough of that though to keep somebody busy and have a job. I think that is one of the hardest things is trying to decide how much staff do you really need? Because on a given day, we're probably overstaffed. But at the same time, we've had it happen like during COVID, where we've had 3 people out with COVID. And then now we're having to lock the door and say you can only come in if you have an appointment. Otherwise, the door is locked because we can't field all the people coming in. I think that's the hard part is that I don't know that we have enough tasks for a lot of these roles, but if somebody wasn't here or if they took an extended vacation, then yes, we would need them. We just always end up getting by with what we have if somebody's ill or whatnot and taking on extra duties. But then there's other days where I'm like, gosh, I feel like we don't really need all these people. And our team just really does a great job of helping each other out that I think that also obscures a little bit how many duties we necessarily have or roles we need because we all mix and mingle and help each other out. We all know how to do them. That's one thing when I trained everybody or we had other people training when they came in is that how we train them, we tend to train them to learn everything. So then that way, if we do need to have somebody step in, somebody else can do it.
And what about reevaluating your processes? Because you've been open multiple years, and even with changes in staff, generally processes stay the same. Like you're saying, these tasks have to be redistributed, the tasks don't change. So, do you ever reevaluate, and what process do you use to reevaluate? Does this standard operating procedure, this way of us doing things, does it still serve us the same as it did when it was created?
Yeah, we do. We do that. There's even some policies that we've made that were like, oh gosh, why did we make this policy? Because I think we just did it because we were all frustrated and now we don't really need it. But I would say that we don't change a lot now. And one of the reasons why is because what we did notice is when we were making policies or even setting structure, we were changing things often because we're like, oh, that doesn't really work for us now. It might have been, but it doesn't now. But every time we change things, that's really frustrating for people too, because for some people, change is not something they can grasp quickly and then it overwhelms them. And we've had some people that we've almost lost employee wise because they're so overwhelmed that things aren't staying the same. And we do need to continue to change to keep up with everything. Cause that's one thing since COVID is that, I mean, I've never seen medicine change as much as it has since COVID. I mean, every year, every couple months, there was something changing. And I thought, this is crazy. Like medicine has been static for so long. And then we were changing policies, procedures, everything so quickly, nobody could keep up. But we do reevaluate certain things like, oh, maybe who has to be in staff if we do a phlebotomy or an IV, or, more like medically who's on and for more of a safety standpoint. But as far as from like an administrative or our day-to-day operations, we really haven't changed those in quite a while. And mostly it was because we found a nice rhythm, but also because when we were changing them pretty rapidly, people were like, okay, who's doing this and who's doing that? It just got to be a little too confusing.
And what about, because you're way closer to Target and other things that we don't have in rural America, even though you are rural comparative to like Omaha, but like, do you have medical students, residents who come and shadow, and how do they serve and how do they learn how to serve at your clinic?
Before COVID, we had quite a few residents come in and had a couple of medical students. And then since then, we just had a resident last couple weeks. But I would say it really is more of shadowing. They haven't done a whole lot of seeing patients. And I really believe it's because we're in this DPC setting where they want to see me. That's who they're paying to be seen monthly. They have no problem with the person coming in, but they don't even want to do the traditional where you send the student in or the resident, they interview them first. And like it's not time reasons either. It's not because they're like, oh, we don't have time, because they're used to sitting there and having a longer appointment. They just honestly want to see you because they've paid to do so. So I don't know. I let them come and I let them shadow me, but I don't really think they get like this huge learning. They learn a ton of business is what they learn, truly, I feel like, which is the opposite for us, right? We learned all kinds of medicine and no business before.
And
But
that's what I was going to say. I think it's great lessons for them to learn, because especially
yeah,
if one is looking to DPC, you have to be aware of business, and you don't have to necessarily have an MBA, but in terms of strategy and I guess listening to the voices of yourself and other people who've been on this podcast, in every single episode, you hear about the business aspect of DPC. And so I think it's so cool that I love how residents have training in point of care ultrasound. I love how residents have training in that they have the knowledge that you do not have to go into a corporate model based practice after residency. So things that you and I didn't have because they weren't things back when we went to
yeah.
medical school. Yeah. Yeah.
Now people are really considering them for sure.
Yeah, absolutely. Now, in terms of your staff, hiring and firing, I mean, clearly you have been through both. Do you have any best tips on how to look, how to hire, and how to say to someone, hey, this is not going to be able to work out in the future?
Well, I think when you hire somebody, we had a time a couple years back where we might lose two of our nurses. And so we are looking to hire people again. And you're obviously for DPC, especially in our clinic, you're looking for somebody that's super strong, that has multiple skills. They can really learn quick. They take initiative. But our setting is just so unique because it is a small town, and you have to not only make it work with staff, but you have to make it work with the patients too. And so for me, I was lucky enough that we were able to retain the two nurses that we were going to lose. And then the two nurses that we hired in their place, they became more like PRN part-time, and we just had them fill in as need be to see if we would end up needing them full term in the future. But I think the biggest thing would be if you are as lucky as I am, where a lot of our staff has worked together at the hospital prior. So we were lucky enough to know that it would most likely work well. There are actually some downsides to having worked together before. Maybe sometimes people don't work well together, but I knew that our staff would work well. But it is still trying to find where that person fits in the model. So it's not a stomping ground, and they're all trying to do the same thing and compete. But I think it's a big deal to have people be part of that hiring process. So having your staff come in and do interviews and meet them. Really, if you're not going to have them meet any of the people you're bringing in, at least sitting them down and explaining, hey, this is who I've been looking at. This is what their qualities are. Our PA that we just hired every time that I would meet with her, I would come back and tell the staff, this is who this person is. This is what she's like. I took her to dinner and I took two of the nurses with me that would work more one-on-one with her than not. They went to dinner with me and they met her the very first time. Then it was another time that even one of the nurses said, why don't we just have her come shadow in the clinic to see how that day goes? And I was more than happy to do that. But the fact that the nurses showed initiative and said, hey, let's try this, I really appreciated that because that was them getting involved. Same thing with some of my other nursing staff. They brought me resumes before of people that, hey, do you want to look at this person? I think she might be a good fit. It might be somebody that we can train and teach how to do some of the skills, even though she doesn't have them right out of the gate. Having them really buy in and be part of that is huge to me because I'd much rather have my staff bring me a resume or go to dinner with me and a PA or do that and have them be involved than just bring somebody in, set them down and be like, okay, now everybody get along with her or him. So I do think if they can try and be a part of the hiring process, as far as the firing process, nobody wants to ever do that. And first of all, anytime that somebody gets let go, I sit down with myself multiple times and figure out, am I doing this for the right reasons? Is this black and white? Am I following policies? Am I following emotion? Am I following other voices that I shouldn't be listening to because they're not the boss? Am I getting good input? Is that emotionally driven? I'm sitting there thinking about this days and weeks at a time, unless it's something that I've been fortunate that it hasn't had to be something that it's like, okay, tomorrow you need to be walked out the door because this is hazardous to someone or our staff. But the times that I've had to consider it, I really had to sit down and think about it. And we do lunch and learns, and one of our old patients does our lunch and learns when we do them on like personality testing and some of these other like color groups of what color you are. So my staff laughs because when we do these, it's very obvious what color I am because whenever they start listing like off all the different traits, they're like, oh, that's me. Oh, yep, that's me. That's me. And one of them is that I give everybody the benefit of the doubt and give everybody as many chances as possible. Like, I don't like to cut relationships off. Like, I am committed to the people that I hire, that I work with as patients, as relationships, Henry Schein, all of these different places. I always tell all these distributors and ancillary services I use, unless you do something completely wrong, if I chose you, I'm committed to that relationship. And I think that's really important because I don't think relationships are where they used to be in the past. But same thing with my staff. It's hard to fire someone unless I know that there's really a reason. And so I just encourage anybody that's firing someone that you do have those lists of why are you doing this? Is it policy driven? Making sure it's not emotional driven, that it's from some outside word that you shouldn't be listening to. And so when I've done the firing on our end, everybody's gotten a couple warnings by that time. They've met with me. I did get great advice by one of my mentor and colleagues before, Dr. Jacobson, that anytime you're meeting with one of your staff, no matter if it's maybe for a positive or a negative, you should be documenting down what date you met with them, what you're talking about. Because here at our location, I'm the only one meeting with them. And back at the hospital, it would be the CEO and maybe the CFO or the CEO or the admin assistant. There was always somebody there to say, this is what happened and vouch for it, right? I don't have that, but I am documenting down, like, this is what we talked about on this date. This is what written warning I gave them. I'm usually printing something, keeping it in an employee file. Everybody has their own employee file. I have everything from my reviews with them to if their time card is off to their raises, everything. Their files are all pretty big. Their PTO they've asked for, all of that. So I just like to know that if somebody's not going to be there, I have the reasons in my brain of why, and we've checked all those boxes. And I usually try and make it end on a good note because there's also times where I've given good references or talked to their next employer, or at least had to be honest with them of why I had to let that person go. But I do try and remember everybody's human. And unless they've really done me completely wrong, like, what was it? Haley Miller saying, took all the doorknobs off my doors and left that day. Nobody's done that. Sorry, Haley. I wish I could offer you compassion there, but that hasn't happened. unless something like that's happening, I'm really trying to do my best to remember at the end of the day, they're giving their best and it just may not work out at our location.
I appreciate you sharing with all honesty and with your experience, what you have lived in, the person who is in the driver's seat of the Healthy Human DPC, and where the staffing has come into play there, and everything you've done with the staff there. So thank you so much for sharing today. It's been fantastic to at least get to talk with you longer than I saw you at DPC Summit.
That's the truth. This girl, her booth was so hopping, you would have thought it was the dance floor. Like, no joke. She was jumping around from one conversation to another. If I would have worn my Calabrasca shirt, maybe you would have noticed me. Maybe.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Maryal Concepcion.